let that go live. Perfect, amazing. All right, well, let's get started. Thank you everyone for joining us today for our flu webinar, what you don't know about the flu. So that's super exciting. Dr. Andrews, why are you pinned? Can everyone hear me? Yes, okay. Yeah, so thank you for joining us at the Lung Association for What You Don't Know About the Flu webinar. We at the Lung Association are very passionate about spreading awareness about the importance of protecting ourselves against the flu and the benefits of getting the flu vaccine as well, and while dispelling common myths. So we thank you all for joining us today to learn from our experts around the flu and the flu vaccine. Huge thank you to our presenters for joining us today and for creating some fantastic presentations and taking the time out of their schedules to share this valuable information with us this afternoon. We have 3 presentations this afternoon, and we will have a 5-minute Q&A period after each presentation. During our presentations, please type any questions into the chat and we'll address as many as we can in the allotted time. And without further ado, I would like to introduce our first speaker, Dr. Shelley McNeil. Dr. McNeil completed her medical education and internal medicine residency at Dalhousie University, followed by a 3-year fellowship in infectious disease at the University of Michigan in Ann Arbor. Dr. McNeil returned to Dal in 2000 and is currently a professor of medicine and pediatrics and the chief of division of infectious diseases with the Nova Scotia Health. Dr. McNeil is a clinical scientist and the deputy director of the Canadian Centre of Vaccinology, where her research focuses on immunization policy, program evaluation of epidemiology with vaccine presentable diseases in adults, where they focus on elderly assessment of the effectiveness of vaccines for prevention of serious outcomes in adults and clinical trials of new vaccines targeted at adolescent and adult populations. Today, she will be presenting Living Better Longer, the importance of the flu vaccine for older adults, reviewing the burden of influenza in older adults, and highlighting the effectiveness of influenza vaccines for preventing hospitalization due to influenza, and highlighting the importance of preventing influenza during the COVID-19 pandemic. Thank you so much for joining us today, Dr. McNeil.
Thanks so much. Thanks for having me. Pleasure to be here and to talk about something other than just COVID. This is another virus, of course, and one we used to pay all of our attention to this time of year, but it's really important to remember about influenza now, particularly in view of the ongoing COVID pandemic. So happy to be here to chat with you and answer any questions you might have around those things. So as mentioned, I'm trying to advance my slides. Interesting dilemma. Just one second. There we go. I'm a vaccine researcher part of my time, so I have had funding for grants and contracts and clinical trials and the like from pretty much everyone who makes vaccines. Importantly, I am going to talk to you a little bit about some of our data from Canadian studies looking at how well influenza vaccine works, along with Dr. Andrew, who's my co-lead for that study, and those studies were funded by GSK and Pfizer largely. So Lacey already mentioned the objective, so I'll skip over that, but we're going to talk a little bit to you today, all 3 of us, in fact, about the overall burden of influenza on Canadians and Canadian older adults in particular, because both influenza and COVID-19, more new on the scene, can cause significant infection burden and illness and hospitalization and deaths. And all 3 of both of those viruses impact older adults more than they do the rest of the population. So when we look at influenza, we conventionally report, based on Canadian surveillance data, about 175,000 visits to emergency departments, about 12,000 hospital admissions due to influenza each year, with about 16% of people who are admitted to hospital with influenza needing to be in the intensive care unit, and about 5% of them needing to be on a ventilator, and about 3,500 deaths per year. More recently, we've had data available about COVID-19, which shows that in this pandemic, recognizing that this virus is new to all of us, none of us before vaccine had any immunity to the virus. We've seen considerable impact of the pandemic that you've watched, of course, unfold in the news and in Nova Scotia as well, where we've seen about 1.7 million Canadians hospitalized with COVID-19, with COVID-19. About 87,000 of those have been hospitalized, about 19% in ICU, and about 2.5% requiring a ventilator. So the rate of hospitalization with COVID-19 appears to be higher than it is with influenza. And we've seen over 28,000 deaths due to COVID-19 in Canada. Both influenza and flu, as I mentioned, impact and COVID-19 impact older adults in disproportionately than they do the rest of the population. So we know that in Canada, about 15% of the Canadian population is over the age of 65. But despite that, about 67% of hospitalizations due to influenza and about 88% of deaths due to influenza occur in that group of people over the age of 65. So really, most of the serious burden with influenza rests in older adults. Similarly, about 63% of hospitalization due to COVID over the pandemic have been in people over the age of 60, the way they report COVID data, and about 93% of all deaths due to COVID have been in people over the age of 60. So in both cases, these viruses impact older adults more than the rest of the population. Importantly, as we age, some of us will acquire chronic other medical problems, heart problems, lung problems, diabetes. And Dr. Neem is going to talk a lot more about the impact of influenza on those other underlying medical conditions that many people have. But overall, we know that the risk of death due to influenza is higher if you have underlying other medical problems. So in people with underlying chronic heart disease, the risk of dying from influenza is about 5 times greater than in people without heart disease, and about 12 times higher in people with chronic lung disease, such as COPD would be the most common of those. And in people who have both heart and lung disease as chronic problems, the risk of dying from influenza is about 20 times higher. So although it's really important for all older adults, just even based on their age, to protect themselves against influenza by getting influenza vaccine, it's even more important that people who have underlying medical problems at any age seek out and get the flu vaccine each year, because they will be at even higher risk of getting serious disease due to influenza if they catch influenza. I think Dr. Neem is going to use this similar slide because it is one that really highlights the fact that when we think about influenza, it is a respiratory virus. So it's a virus that gets into the lungs and causes pneumonia, so cough, fever, just muscle aches, shortness of breath, things like that. So it's a direct infection of the lungs. It can cause exacerbations or worsenings of underlying lung disease, as I mentioned, so COPD exacerbations, asthma exacerbations, etc. But it also can be an indirect trigger for lots of other things to happen in people who have underlying medical problems. So I'm going to let Dr. Neem talk more about those in a moment, but important to realize that influenza is not just the acute problem. The 1 or 2 weeks of feeling miserable with the flu is not the only impact that influenza has on our overall health. It has impacts on all of our other medical problems, which Dr. Neem's going to talk about. And it also has impact in older adults, extending beyond the time when people are acutely ill, because it really can affect how well people do and their ability to function in the longer term. So I'll let Dr. Andrew talk about that in more detail. I'll show you just a little bit of information about the risk of heart attacks and strokes related to flu. This graph shows the risk of having a heart attack and the risk of having a stroke in the few days following having an acute respiratory illness or acute influenza. The yellow line is the rate of having a heart attack or stroke after a flu vaccine, and the pink line is the risk of having a heart attack or stroke after having influenza. And you can see that the risk of heart attack in this study, the risk of heart attack was about 5 times higher after having influenza than it is at baseline. And the risk of having stroke is a little over 3 times higher with influenza. So we know that influenza, and again, Dr. Neem will talk in more detail about this, but we know that influenza not only causes that acute illness, but it can precipitate lots of other bad things happening. And we're increasingly aware of what those things are and the impacts that they can have on overall health. But particularly, we have really good emerging data about the risk of heart attacks and strokes in people who have had influenza. So, of course, if that's true, then if what I just said is true, then we should be able to show that getting a flu vaccine will prevent heart attacks and strokes. And in fact, there's been lots of studies over the years that have suggested that influenza vaccine will prevent heart attacks and stroke. But it takes a lot of people in a large trial to be able to prove that is true. So investigators do what's called a meta-analysis, where they'll combine a whole lot of studies that by themselves may suggest that the flu vaccine prevents these things, but may not be able to prove it because there's just not enough people in the trial. And so based on those meta-analyses, we do know that if we look at an outcome that includes cardiac death, heart attack, stroke, unstable angina, or need for urgent bypass procedures, if people who have had the influenza vaccine is able to reduce the risk of those things happening by about 1/3. And in people who have had a recent event, one of those things happening recently, heart failure or a heart attack or something, you reduce your risk of having that happen to you again by about 2/3. And sometimes that's a little bit hard to put into context. So we in medicine use something called the number needed to vaccinate. And that just means, how many people do we need to vaccinate to prevent something bad from happening? So in the case of things like cardiac disease and stroke and heart failure, for every 58 people we vaccinate, 1 less person will experience one of these things. If people have underlying heart disease and have had something recent happen to them, like a heart attack or heart failure or something like that, then for every 8 people we vaccinate, 1 less person will have that happen to them again. So that's a really important secondary benefit of flu vaccine, because by preventing flu, we're also preventing some of these other bad things from happening down the line. The reason that people who are older are at higher risk of influenza is because of something called immunosenescence. And that just means that as we get older, our immune system is less able to respond to infections. And we're generally more prone to all different types of infections, certainly to influenza and COVID-19, as I showed you. The challenge, of course, is that because our immune system isn't working as well and we're at increased risk of influenza and COVID, our immune system is also less able to respond to vaccine in a way that allows us to be protected following vaccination. So though we look at year by year how well flu vaccine works, and soon we'll be looking at how well COVID vaccine works year on year, what we see generally speaking is that the vaccines don't work quite as well in older people as they do in younger people. We've been, Dr. Andrew and I, along with many doctors across the country and others, have been looking at how well vaccines work in Canada to prevent hospitalization and death due to influenza. So we run this network called the Serious Outcome Surveillance Network, which is a research network sort of focused across the country. The number of cities and sites involved depends year to year, but you see here that most recently, we've had about 9 hospitals in 4 provinces doing influenza surveillance, and about 11 hospitals in 4 provinces doing COVID-19 surveillance in hospitalized adults. And this is just a summary, really, of some of our information that gives us a broad sense of how well flu vaccines work in Canada to prevent hospitalization. So overall, you can see here that overall, flu vaccines in Canada prevent about 42% of hospitalizations. So that's a really important benefit. I showed you that it's not just the hospitalization we're trying to prevent, but also all the bad things that can happen afterwards. And Dr. Andrew and Dr. Neem are going to talk about that further. But you can reduce your chance of hospitalization significantly by getting flu vaccine. Though the difference is, as we expect, that older people may not be quite as well protected as younger people. You can see that the risk of hospitalization is significantly reduced. So 40% chance of 40% lower chance of hospitalization due to influenza, even in the older population and people over the age of 65 who are vaccinated compared to those who are not. So overall, we're able to prevent about 40%, we'll say, of hospitalizations with flu vaccine. That does depend somewhat on which strain is circulating. So there are 4 different types of influenza that can circulate. Well, largely we'll say 4. And depending on which one is circulating in a given year, we may see slightly higher or slightly lower benefit of vaccination, but overall about 40% of hospitalizations are prevented. Importantly, this is true for both flu vaccine and for COVID vaccines. Even amongst people who get influenza after receiving vaccine, the risk of serious outcomes is reduced further. So if we look at how well the vaccines prevent the need to go into an ICU or to die from influenza, you see that the vaccine effectiveness is higher. So the effectiveness to prevent ICU admission or need for a ventilator is about 55%, still around 50%, even in older adults. And it prevents death in about 75% of people. So if you get flu after flu vaccine, your risk of severe disease is significantly lower. So when we think about flu vaccine effectiveness, I always sort of think about it in a glass half full or glass half empty way. Some people would argue, well, if the vaccine's only 40% effective, is that good enough to make it important? But obviously, if we can reduce the risk of hospitalization by 40%, that's a really important benefit and a really important reduction in the number of people hospitalized with influenza, and then subsequently all the things that will happen to them after they're hospitalized that Dr. Andrew is going to talk about. So 40% effectiveness is a really important thing. And again, that's not just the effectiveness against preventing someone from catching influenza. It's the ability of the vaccine to prevent hospitalization due to influenza. So really important benefit. And the effectiveness of the vaccine to prevent death due to influenza is 75%. So these are really important vaccines that we really strongly encourage everyone to get. Another point of controversy right now is what's going to happen with influenza in the era of the COVID pandemic, and no one knows that. But we were lucky in the last year or two with COVID circulating broadly not to have a lot of influenza in Canada and not to see a lot of hospitalizations due to influenza. But we're all very worried that that will not be the case this year. We know that in the most of the first year of the pandemic and all of the second year of the pandemic, we were largely not interacting with each other. We were all wearing masks. We were staying in small groups. We were not going into large public spaces with people who might be infected and pass viruses around to each other. So those public health measures did reduce COVID-19 transmission, but they also significantly reduced influenza transmission. And over those couple of years, very few of us got influenza. So we're, of course, all very worried that this season we may not only see influenza again, but that we'll see it in a much worse way than we would have seen it in other seasons, because we haven't had it for a couple of years. People haven't had their immune system sort of stimulated to protect them against influenza because it hasn't been around for a couple of years. And so, like other viruses, which we're already starting to see more commonly than we would normally this time of year, we're very concerned we'll have a bad flu season this year. So it may in fact be even more important to get influenza vaccine than ever before, because this year could potentially be a bad flu season. And the other reason it's important is that we know that our hospital systems are very overwhelmed by COVID-19 admissions, and we need to do everything we can to try to reduce hospitalizations due to everything we can prevent hospitalization due to try to protect healthcare systems and allow them to continue to be able to deliver care for everything, including flu and COVID. So the more people we can keep out of hospital with flu, the better for many, many reasons. So 42% or so effectiveness against preventing hospitalization, very important benefit for people, and why we recommend that everyone gets vaccine. Of course, we'd love to have vaccines that do better than that and prevent more hospitalizations. So there is work There is several strategies that have been used by various companies that make flu vaccines to try to make that protection better. Those include broadening the vaccines to include all 4 strains. Most of our vaccines used to include 3 of the 4 types of influenza that tend to circulate. All of them now have all 4 strains. So that's an important way to improve how much the vaccine prevents disease. Some vaccines add immune boosters to the vaccine to try to boost the immune response to the vaccine and therefore lead to better protection. And then the most successful strategy for improving how well the vaccine works is to increase the dose of the vaccine. So if we give older immune systems a little bit of a vaccine, they can respond, but if we give them a little bit more of the vaccine, they respond much better. So there is a vaccine, a high dose influenza vaccine that has the 4 strains of influenza in it, that basically uses 4 times as much as a higher dose effectively of the vaccine, and is otherwise very similar to all of the other vaccines. But this one has 4 times as much of what we call the antigen, or the flu, parts of the flu that we're trying to prevent against. And in studies that compared that vaccine, that higher dose vaccine, to a usual dose vaccine and looked at how well it prevented influenza, it was shown that the high dose vaccine was about 24% more effective at preventing influenza than the standard dose vaccine. And this was in older adults. And as you might expect, that benefit was even higher in people who were even older, who may be less likely to respond well to the standard dose vaccine. And that better protection extended into people who were frail. So the National Advisory Committee on Immunization, which is the body that you hear about on the news a lot lately with COVID, has always been the group that we look to of scientists and experts that make recommendations for all vaccines in Canada. And because the evidence shows that the high dose vaccine provides better protection for older adults, particularly when this one strain of influenza is circulating, which it often does, the National Advisory has recommended that, if possible, people over the age of 65 should get a high dose vaccine rather than the standard dose vaccine. The challenge, of course, is that the high dose vaccine is not part of the publicly funded programs in all provinces. So in Nova Scotia, we do have the high dose vaccine in long-term care facilities, but for people who are living in the community, they need to get a prescription for that vaccine and purchase it through a pharmacy. Just one word about COVID vaccines, because I know many people have lots of questions. Clearly, these vaccines are highly effective and very safe. People who are fully vaccinated over the pandemic in Canada have accounted for only about 6% of the overall number of cases, about 5% of hospitalizations, and about 6.5% of deaths. So the vast majority of cases, hospitalizations, and deaths have been in people who are not fully vaccinated. Being fully vaccinated against COVID-19 reduces your risk of hospitalization by about 80%, so even better than the flu vaccine. We do recommend that all Canadians over the age of 11, and soon hopefully children, receive 2 doses of COVID vaccine. Importantly, if you're thinking about COVID vaccine, if you have people or are living in a long-term care facility, or you're immune compromised mostly by medication or some underlying problems with the immune system, you're now recommended to get a 3rd dose of vaccine to boost that protection against COVID-19 as we continue through the pandemic. And it's likely we'll hear word soon, I suspect, that people in the community, or some older people in the community, will be eligible to get a booster dose of COVID. I don't know if and when that will happen, but just keep an eye out for that, because if a booster is recommended, you may be able to get another dose of COVID vaccine. And really importantly, as we're now all going out to get our flu vaccine, if you do need another dose of COVID vaccine, you can get it at the same time or any time before or after your flu vaccine. So those are my main messages. Again, keep influenza top of mind. Don't forget about it in the context of pandemic. We shouldn't be reassured that just because there's COVID around, we won't see influenza start to circulate again. In Nova Scotia, we generally start to see influenza just before Christmas and then continuing through then, but we have had seasons where it starts much earlier. So go get your influenza vaccine as soon as you can. It is available now. The pharmacies have all started using it. Ask your doctor whether you should be getting a COVID third dose or booster as you move forward, and you can get them at the same time when you go to get your COVID booster and flu vaccine. And ask your provider about high dose influenza vaccine, and if you can, it does provide some better protection, so you can get a prescription for that and just take it to a pharmacist, and they can both fill the vaccine prescription and give you the vaccine. So I will stop there. Thanks to the many people who work with me, including Melissa. And I'll turn it over to, I think, Melissa next to talk about the broader impacts than just flu illness itself.
Thank you so much for that really informative presentation, Dr. McNeil. That was great. We do have a couple quick questions just to get your opinion on, since we might as well take advantage of your valuable expertise. Do you think the province may consider adding the high-dose flu vaccine for all Nova Scotians over 65 to be publicly funded?
I hope so. I don't have any inside scoop, but we've been advocating for that, so I hope so.
Absolutely. And then another one, this is a two-parter. What do you think the biggest reason is for people not to get the flu vaccine, and then how can we address this?
I'm not sure. I mean, some people, there are always people who worry about whether the vaccine is safe and need to have more information. So, you know, there's lots of good places to get information, including the Lung Association of Nova Scotia. I'm sure about the safety of vaccines. Sometimes people just don't think about it. You know, they don't think that they're likely to get the flu because they feel like they're healthy and they eat a healthy diet and they exercise. And that, of course, is a good thing to do for your health, but getting vaccines is just as important as that. And whether you're healthy or not, flu doesn't care, COVID doesn't care. And you definitely can still get sick and really sick with both of those viruses, regardless of how healthy you are otherwise.
And I have one just popped into our chat. Do you know what the approximate cost of the high dose vaccine is for flu off the top of your head?
Marilyn? I don't, but I suspect Dr. Neem does it. Last year, I think it was around $65.
Marilyn, I can always follow up with you after this webinar as well. Thank you so much, Dr. McNeil. This is fantastic.
I might ask one question, Lice.
Absolutely.
Dr. McNeil, with the, I guess my question is, what was the level of flu vaccine rate prior to COVID? Amount of Nova Scotians that would be getting their vaccine? Yeah.
It was very high in long-term care facilities, over 90%. In our studies, it's looking at overall, it's around 50 to 60%.
Do you expect it to be higher this year?
I hope so. I mean, I think people have maybe been lulled into a false sense of security about influenza, and you know, not to be sensational, but we all are really worried about the potential for, excuse me, a severe season, given that we haven't had flu around and all of us have been sequestered in our homes. So we really, and you know, our hospitals are so full right now that we always see a blip in the winter with influenza hospitalizations that pushes the system almost to the brink. If we see that same blip in the middle of the pandemic, we're not going to be able to do surgeries. We're not going to be able to do all the other things, take care of all the other illnesses. So for people's own personal benefit, I think this is a really important year to get a flu vaccine, but also for all of us to do what we can to protect the healthcare system. This is a really important year for us to get flu vaccine.
Yeah, no question. As an advocacy group, that's what we want to get that messaging out. And if there's any other ways that you think that we can do that through the Lung Association, we're always open for ideas on that, but we'll continue that messaging. Thank you.
Okay, well, I'm going to turn it over to Dr. Melissa Andrew. Dr. Andrew is a staff geriatrician and professor of medicine and geriatrics at Dalhousie University in Halifax. She completed training in internal medicine and geriatrics at Dalhousie's, a master's in public health at the London School of Hygiene and Tropical Medicine, and an interdisciplinary PhD at Dal on the subject of frailty and social vulnerability among older adults. As a part of the Canadian Immunization Research Network Serious Outcomes Surveillance Network, she conducts influenza, pneumonia, and COVID-19 surveillance. Her research interest includes how frailty impacts older adults, responses to vaccines, infectious illnesses such as flu and shingles. Today, she will be presenting frailty, function, and the flu, and will be providing us an overview on the long-term impacts of influenza on function, frailty, and the need for long-term care, as well as how older adults with influenza may not have classic symptoms of influenza-like illness and how preventing influenza can help avoid frailty. Thank you so much for joining us today, Dr. Andrew.
Thank you. It's great to be here. So there we go. So like Dr. McNeil, I do various research studies that have been funded by different agencies, including some public funders like the Public Health Agency, as well as some industry funding. So I'll start with my key points and then we'll expand on them as we go. So we've heard some really great information on how important influenza is in terms of the known complications of hospitalization, the acute period of illness during the week or two, usually when people are unwell at the time. But we often don't think about the longer term ramifications. So we really need to start thinking about longer term impact of influenza, especially on people's function, their independence, their ability to live in their own home, and potentially the need for nursing home placement, which are things that most older people value a lot. They value function, independence, and really try to avoid having to go to a nursing home. Also, older adults may not present or with the usual sort of symptoms that people think of when they think of the flu, which has important implications, and we'll get a bit to that. And then, as you hinted off the top there, we'll really talk about how influenza can contribute to worsening frailty and function, and it's important to do what we can to avoid that. So you might be wondering what frailty has to do with influenza. Influenza is a little virus, and how does frailty matter? So we'll talk a bit about what frailty is and why it matters. So frailty is a state of like a holistic understanding of somebody's health status that comes with vulnerability to bad things happening in their health. So somebody who's not frail, if you look at this screen here, you can see somebody who's not frail, they're independent in their activities of daily function, and they get a minor illness, even like an infection, could be influenza here. They may have a blip where they decline to some degree in their health, then they have a recovery period, and then they get back to where they started. But somebody who is closer to being dependent on other people, who is more vulnerable in terms of their overall health status and other underlying conditions, such as chronic lung or heart conditions, for example, they can take a much bigger hit with that same illness. They can take a lot longer to recover, and then they may or may not get back to where they were before. And that is really a hallmark of what frailty means, is that somebody has difficulty recovering from an insult. So as Dr. McNeil mentioned, we have had this surveillance network for influenza and now for COVID that's been going for a decade. And one of the really unique things that we've been doing over the years is considering frailty and function, and these things that are really important to older adults, especially in our work. So the frailty measures that we use, we have two of them. One is an index that's based on essentially a comprehensive geriatric assessment, a view of a person and their daily function, their hearing and their vision, their underlying comorbidities like lung disease, heart disease, neurological conditions, their bowel and bladder function. Everything gets put into the one measure that understands their health holistically. The other measure that we use, which is perhaps a little more approachable, easier to understand, is this thing called the Clinical Frailty Scale, which was developed here at Dalhousie by Ken Rockwood and colleagues, and has been applied very widely around the world. So this categorizes people into these 9 groups, and as the numbers get higher, the frailty gets higher too. So everybody fits here somewhere. The 1, 2, and 3 are low frail, not frail, managing well, able to be active. Then we get into people who are mildly, moderately, and severely frail, and then very severely frail. So this scale will come up later in what we're talking about. So these are some results that we've found over the years from our surveillance network. And it talks about the importance of considering age and frailty in relation to how well these vaccines work, which is something that Dr. McNeil had started talking about before. So one interesting thing, and this speaks to the question around the coverage of flu vaccine, is that unfortunately adults, especially in younger age groups, don't get vaccinated very much. This was before COVID, of course, and we hope it increases, but still. So in these pooled seasons, several seasons a number of years ago, we found that only about 20% of the younger adults were vaccinated, and this increased with age. Now, if they ended up hospitalized with influenza, even some young people can die from influenza, quite unfortunately, but the rate of death goes up quite a bit more for people who are older. Intensive care use goes down actually with age, and that is a bit of a different question. It tends to have to do with people's goals of care and deciding not to go for these more invasive treatments. When we think about frailty, we see a similar pattern. So people who are not frail, unfortunately, didn't have very high uptake of vaccination, but it gets higher as people get more frail. And so that, if you don't take that into account when you're looking at how effective a vaccine is, you might think that all these people who got the vaccine, they still got sick. So what's up with that? But it's because their frailty is so high, they may have had a lower or a not as good response to the vaccine. Of course, as people got more frail, their death rate was even higher than with age. And so that's something that we see across all studies, that frailty is a really better way to understand somebody's risk than just age. And frailty, as we talked about before, includes things like underlying health conditions. So this is a story of what happens to people when they come into the hospital. And this is pooling together data from a number of different years and seasons. So here we have 100 older people coming in who are at a certain level of function, whatever their functional baseline is, living in the community. They get sick with influenza during this season. Unfortunately, 12 of them will die. And here we have some of them come out relatively unscathed with their function still intact, about 68 of them. But we have this group of about 20 people who have a functional decline, meaning their functional levels and ability to do basic things for themselves, like go to the bathroom, get dressed, goes down. For about 9 out of these 100 initial people, that functional decline is persistent after the hospital discharge, but it's mild. So they're able to do maybe one less thing independently and need a bit of help. But for more of them, unfortunately, these 11 people had a catastrophic decline in their function. So they really need a lot more help in their basic activities of self-care. And then 3 of them may end up having to go to nursing home when they didn't come from a nursing home. So this is just another way to understand some of these functional outcomes that are so important. Here's just a visual of how we calculate vaccine effectiveness in our surveillance. So what we look for is all of these people are in hospital. We find the people who have the flu, the influenza, and then we have the people who don't have the flu, but who had, came in for a similar type of hospitalization. And then you look to see how many of them are vaccinated. And from that, you can calculate how effective the vaccine was in protecting from hospitalization. So here's some examples, and we saw some similar examples. That this was a season where we took a deep dive into the effect of frailty on responses to vaccine. So what we found is that, say, for older people, if you don't account for any of the underlying health conditions and frailty, the effectiveness looked to be about 45%. But once we were able to adjust for frailty and these other things that are down here, age, for example, smoking and whatnot, we saw that the vaccine effectiveness actually was much higher. And in this season, it was actually higher in older people than in younger people. And a key take-home point from that study was that frailty alone was the single most important thing to take into account when we're thinking of how well a vaccine is going to work for an older person. This is another way to look at it. If we divide these older people up into groups of frailty, these are the non-frail group. These are the sort of pre-frail or like almost frail. These are frail. All of these people had, reasonably good vaccine effectiveness in preventing them from getting into the hospital with the flu. It was a bit lower for the people who were starting to get frail. But for the very most frail, the vaccines weren't as effective. And these are the people who especially benefit from these strategies that Dr. McNeil was mentioning earlier to make these vaccines better. I mentioned that one of the problems that we have with older people or people who are frail and the flu is that we don't detect them very well when we look for the usual symptoms. So there's this definition that's commonly used of influenza-like illness, and it's like an acute thing that comes on suddenly, and it has a fever and a cough. And if you look at all of the people who are admitted to the hospital, and we know they have the flu, less than half of them had a fever and a cough. So you can't wait for the fever and cough to indicate to you that somebody has the flu. And that's the case even if we relax the definition a little bit so that you don't have to have so high a fever, it gets a little better. But it's really just showing us that we have to have a high index of suspicion that an older or frail person may have the flu even when they don't have a fever. This is just a couple of slides to show you what our experience is looking like with COVID so far. So we've seen a very similar thing with frailty. There's the wide distribution of frailty among people admitted to hospital with COVID. These are the about 2,000 people admitted during 2020. And we found that on the left, we see people who are less than 65. And while 43% of them were not frail, there were a lot of them who were actually frail, even at younger ages. So that's one lesson we can learn. It's not only older people who have frailty. Certainly once people were older, the amount of people who were frail was higher. And like we saw with the influenza, mortality goes way up with age and with frailty. So the blue bars show the percent of death. So there are, tragically, there are people who die across the age spectrum with COVID-19, but it's lower, say 5% under 65 and going to, 28% or so over 85 of these hospitalized patients. But the use of the intensive care unit is higher in the younger groups. That's the red bars. And we see a similar pattern with frailty, so that as frailty goes up, the death rate goes way up. So hopefully now we've seen that frailty is really important when it comes to influenza and with COVID-19. It's important in identifying the illness in the first place and in measuring the outcomes. And it's super important to understand the long-term impacts of influenza in terms of this persistent functional decline. So overall, as people get older, what can happen is that they may get more and more frail. So these are the levels of frailty. And what we aim to do is to help avoid frailty. So in fact, can we prevent or improve frailty? And this is a strategy that's out there with the Canadian Frailty Network, which is a great group for you to be aware of. Here's their website there. They have the strategy called Avoid Frailty, and everything, each letter stands for something, and the V is for vaccinate. So it's really about getting those older adult and adult vaccines up to date, anything that's recommended to try to prevent the illnesses and the disability that can come with them. So I have similar acknowledgements to Dr. McNeil. Thank you so much for your interest, and happy to take any questions.
Thank you so much for another informative presentation. That was really interesting. We do have a question. How do you know for certain functional decline was caused by the flu and may not have just happened anyway?
Yeah, so that's a good question. So what we did in that study was measure their function beforehand, or ask about details of what they were able to do, and then ask about the details of what they were able to do when they leave hospital and then 30 days later. So of course, it could be tied into the fact that they were in the hospital as well, right? But we had a control group of people who didn't have the flu who were in the hospital too, right? So whether or not it's from the virus or from the things that happen around being super sick, being in bed for a week, it's a question of whether that actually matters so much. It's more that the whole package of having the flu, getting sick, being in the hospital leads to this catastrophic functional decline in an important group of people.
Thank you so much for that informative answer. I want to give a moment for any other questions to be popped into either our Facebook Live or our webinar chat. And then we will keep on going. Thank you so much. That was amazing.
Thanks.
Okay. All right. Next up, we have Dr. Dion Niami. Dion is a clinical medicine and vaccine expert with the focus on medical strategies for various indications and early pipeline products. as well as external medicine and scientific stakeholder engagement. With over 15 years experience in large pharma, Dr. Niemi has held many impressive leadership roles, including North America Senior Medical Expert and Country Medical Lead Canada. He has extensive experience as a medical professional, including pediatric medicine at McMaster Children's Hospital and Chief of Pediatrics at Joseph Brant Hospital in Ontario. Dr. Dion Niemi is the Country Medical Lead for Sanofi Canada and the Country Medical Head of Pasteur, the vaccine arm of Sanofi. Today, he will be presenting on the impact of influenza on individuals with underlying chronic diseases, providing us with an overview of the health impacts of influenza, including potential complications of influenza and the risk of influenza exacerbating chronic conditions.
Thanks, Lacey. And you've got control of the slides there, right? So
I do.
okay, so I'll do the please advance, please advance. Okay, so here's the thing. I've kind of run out of time, and the good Dr. McNeil and Dr. Andrew have actually talked about a lot of the stuff I was going to talk about anyway. So I'll try to be scientifically agile and just maybe use this as a bit of a summary. I don't, just the one thing I would like to say is that I have been practicing medicine since 1991, and I still do that. And so I've been seeing a lot of infectious diseases. At Sanofi, I do study a lot about influenza and COVID-19 and respiratory syncytial virus, so a lot about the respiratory infections. And they do have a lot of commonalities, I will say, but let's stick to influenza today. So as Dr. McNeil had pointed out, you know, there's a lot of morbidity and mortality associated with influenza, but I don't think that's really sometimes recognized. And I hear a lot about people saying, it's 1 in 10 chance of getting the flu every year, and so I probably don't need to get a vaccine. But I won't go over the numbers, but you can see that they're fairly substantial. I would say that influenza has the highest death rate of all vaccine preventable diseases. Now, I will caveat on that because we're not actually sure how it's going to land with COVID-19. Okay, so next slide, please. Okay, so yeah, okay. So I think I've talked a little bit about the perception of influenza, and that's changing quite a bit with COVID-19. And people start to understand that respiratory infections can really cause some trouble. Trouble for yourself, you can pass it on. It's trouble for someone else. It can actually overwhelm our healthcare system and pretty much overwhelm our economy, I guess, in a sense too, when we get hit by all of these. I will say that with influenza, you know, a lot of people, they understand the first part of it, which is sort of the upper respiratory tract infection. And they get the fact that you can get a headache and runny eyes, runny nose, and a sore throat and a cough. They understand that. And they are sort of, I understand the sort of the fever bit about it. But that is really for maybe sort of a third of the people that are actually getting influenza. And so if I can use the analogy of the iceberg, so that's the tip of the iceberg, and below the iceberg is actually what we get quite concerned about. And this is a situation where, you know, even from a clinical perspective, even from a symptomatic perspective, you can really get those fever, chills, and sweats. You can get lethargy, you can get muscle aches, myalgias, and you can actually be out for 7 to 10 days. And then you can also get complications, and those complications can be what you can see there on the lower part of that iceberg. But you can get pneumonia, heart attack, stroke. You can get exacerbations of chronic lung disease like asthma, COPD, and diabetes. Next slide. So Dr. McNeil also used this slide, and I just kind of put it to you from a perspective. This is when physicians are really thinking in their mind about influenza and influenza complications. They do tend to put it into on the left side, you've got the respiratory or direct effects of influenza, and then on the right side, sorry, you've got the indirect effects, the multi-organ system. So yeah, I mean, I don't want to get into this too much because Dr. McNeil went into it pretty well, but when you've got a respiratory infection in your respiratory system, it generally causes inflammation. Inflammation essentially means that you're going to get swelling and redness and inflammation that's going to kind of block up and clog up your anatomy. So when you're talking about the upper part, well, you can get kind of secondary infections there. It can clog up your nasal passage, your sinuses, and that's giving lots of fluid in there, which bacteria love, and they can give you ear infections and the sinusitis. If it gets into the lower tract, same thing. It's basically getting this inflammation and providing fluid, which bacteria that can kind of work its way down there can actually grow and proliferate. And that gives you bacterial pneumonia. The other thing that it can do is it can exacerbate underlying disease. It's irritating those diseases. So it's irritating if you have an asthma, or it's irritating your lungs if you have COPD. And that can be like kind of the first domino that can cascade into some diseases that get you from your family doctor to the urgent care to the emergency room and then admitted into the hospital. When you're looking at the indirect effects, we tend to talk about it in two ways. One, it can trigger, and two, it can exacerbate. The triggering tends to be in the cardiovascular system, and it can, and I'll go into this a little bit more, but it can actually give you myocardial infarctions or heart attacks, or it can give you strokes or cerebrovascular accidents. And it can exacerbate other chronic diseases underlying, such as diabetes or hypertension or renal disease. Next slide. So just to dig a little bit deeper into the cardiovascular side of things, I mean, when we as physicians, when we actually were asked maybe 10, 15, 20 years ago, you know, influenza, what does it do? Does it cause, let's say, for example, myocardial infarctions? Most of us would say no. The reason we would say no is because we talk about what we see. So, you know, I used to work in the emergency room all the time. And I mean, you know, when we had people coming in with heart attacks, you would be focused on the fact that they were having a heart attack and try to prevent as much damage as possible to their heart, because, you know, really essentially they were dying in front of you. And you wouldn't be asking a lot about history. You wouldn't be saying a week ago, how were you? Do you having influenza or flu-like symptoms? You would just be focusing on that. So we didn't really make that correlation. What actually happened is that when studies changed from kind of clinical trials to looking at real world evidence studies, where we're looking at, so for example, insurance databases, which had massive amounts of information, we were able to start to make some interesting correlations. And the first study I'm going to talk about is the one that's on the slide right now. We can go to the next slide. Oh, sorry, no, you're in the right time. I'm sorry, my bad. So you're in the right spot. Basically, this is from Jeff Kwong. And what Jeff did was he looked at the Ontario health insurance plan. We called it OHIP. And it was a clinical database which looks at all of the insurance claims made when someone comes to see a physician. And what he looked at and tried to elucidate was the relationship between influenza and heart attacks or myocardial infarction. So what Jeff did was he looked at the influenza and the week after the influenza, and he compared that to the year before and then the year after that week of influenza, and he looked at the incidence or the rate of myocardial infarction. And what he actually found is that you had, as you can see on the slide, you had a 6 times increase from the influenza and that week compared to the year before and the year after. When you looked at specific age groups, for example, if you looked at people 65 years of age and older, it was about 7 times higher in the week of influenza. And if you looked at the people who had never even had a myocardial infarction, you would find that they had about a 7-time increase in myocardial infarctions from influenza in that week. Next slide. So here's another study on the other side of the pond. This is from the Scottish group. And what they're looking at here, this is national infection surveillance data linked to their Scottish morbidity record. The study identified adult patients with their first heart attack or their first stroke between the years 2004 and 2014, and laboratory confirmed influenza. And there's about 2,000 people in it. There's people who are over 40, and they were about 60 years of age on a median age. But what they actually noticed is, you can see that on the left-hand side in those blue boxes, that you had a 10 times increased risk of having your first myocardial infarction and 8 times increased risk of having your first stroke within 1 to 3 days of having influenza. And now a lot of people would say, you know, why is this? And this has a lot to do with the fact that when you are getting influenza, what you're doing is you're stimulating your immune system. But your immune system has 2 parts to it. It has an innate part, which is a very generalized part, and then it has an adaptive part, which is a very specific part. And it's a generalized part that seems to cause the problems. It seems to be flicking this first domino when you get influenza and causing the other diseases. So when you stimulate your innate system because you got influenza, you're releasing a number of different types of mediators. These are cytokines and chemokines. We'll talk about the cytokines for a second. So the cytokines are going to help us fight off the influenza infection. That's a good thing. But because it's a general response, these cytokines will also be floating around the body. And then we are looking for things that are foreign, looking for things that shouldn't be there. Well, one of the things that shouldn't be there actually is atherosclerotic plaques or cholesterol plaques, which are in our vasculature, in our blood vessels. And so they can look at them and they go, okay, we're going to get rid of you. And so they start chewing away at those atherosclerotic plaques, those cholesterol plaques, and actually break them down. That breakdown causes a bleed. And then our body says, oh, there's a bleed in the blood vessel. We got to go through our coagulation pathway. So we start to build up these platelets and we create a clot, and heal that little break in the blood vessel, and all is good. The only problem is now you've got a clot that's sitting in the lumen of your vessel, and it's blocking blood flow distally or beyond it. So if that happens to be in your coronary arteries, and you've blocked blood flow that's going distally to your heart, blocking blood flow, blocks oxygen. Therefore, you get death of certain cells. You get cardiac cells. If you happen to be in the brain and you've got a cerebral artery and the same process is occurring, you've got that blocking, block created by that clot. You're blocking blood further on, and you've got loss of oxygen. That's going to give rise to a stroke. So that's sort of the underlying thoughts about why this is occurring. Next slide, Lacey. I don't want to go too much into this slide. Next slide, there, sorry. Oh, there's a build. Yeah. I don't want to. Dr. McNeil went through this slide. I mean, if you've got an underlying chronic disease, chronic heart disease or chronic lung disease, you're going to have increased influenza or attributable death. If you happen to have both, it gets up quite high at 20 times. So we'll just work our way through that. So next slide. The group that people don't talk a lot about, and I'm going to watch the time here, are that people who have diabetes. And what we find is that when you have influenza, it tends to increase your blood sugar. When you have increased blood sugar, you can run yourself into some problems. And so, for example, diabetic patients can get into acute metabolic issues. They call it diabetic ketoacidosis. And that is actually quite a complicated problem to, one, get into, and two, to get out of. And so we find people have great difficulties with that. They get hospitalized and sometimes they can even die. Also, patients with kind of different metabolic decompensations, these people have an increased ability to get infections. And so they tend to run into some issues with that. Next slide. Okay, and so this is just kind of a flow chart of that going left to right. But really what it's basically saying is that with hyperglycemia, if your blood sugars are out of control because of you're diabetic and because you have influenza infection, you can actually end up getting yourselves into either heart attacks, strokes, or immune system dysfunctions, which can give rise to infections, which will get you into the hospital, stay longer in the hospital. And at the end of the day, that's a bad outcome. And this sort of speaks to what Dr. Andrew was talking about in regard to if you actually get sick and you actually are laying down in the hospital for a long time, your frailty can go down quite far. And it's actually difficult to get back up. If you're a healthy person and you're non-frail, you can get sick and you can bounce right back. But if you are a frail person and you get sick and you lay down in the bed in the hospital for 10 days to 2 weeks, your decline is very difficult to get back. Okay, next slide. All right. One of the things I just wanted to make a point on, and I'm going to spin through this really quickly because we're getting close to the end of the hour, but we talk a lot about people at 65 years of age, and that's great. We should be talking about in regard to influenza, in regard to having bad outcomes and complications. But we have to understand that, when you're 50 years of age and above, you actually are in a situation where you actually can also have bad outcomes. People that are over 65 years of age who tend to have chronic disease, 80, 90% of people will have a chronic disease. But if you're over 50 years of age, actually about 1 in 2 have a chronic disease. And those chronic diseases are quite familiar. That could be COPD, that could be asthma, that can be heart disease, that can be stroke, that can be diabetes, obesity, or cancer. And those, so influenza can affect you in this manner. What we tend to look at is a situation when you have that disease, then you're going to have a bad outcome with influenza. But the problem is that even if you don't have those diseases, particularly at the age of 50 to 64, you can get influenza and then you can have the complication. And then now you do actually have a chronic disease. So you were healthy without a chronic disease, got influenza, had a myocardial infarction, and now you have your one chronic disease, right? And so that's where it starts. It tends to start at the ages of 50 to 64. Okay, next slide. I may just pop by this one and go to the next slide. And I'm going to start, go to the next slide. And I'm going to start just kind of repeating a lot of what Dr. McNeil said, which is that we have a group called the National Advisory Committee on Immunizations, and they highly suggest that people should be getting a vaccine for influenza, particularly if you're over 65 years of age. And there's multiple different vaccines that you can get. You can get high dose vaccines, you can get standard dose vaccines, you can get cell culture vaccines, you can get adjuvanted vaccines. I mean, please just get any flu vaccine. But what NACI would recommend, if you have the choice, then in your 65 years of age and older, the science would support that you would get a high dose vaccine over a standard dose vaccine. Now that's very good with the high dose and the standard dose because there happens to be studies out there. With the other types of vaccines, the adjuvanted and the cell culture versus the high dose, we don't actually have that data. So you can't really recommend one over the other. So, but the general thought is if you're 65 years of age and older, because of H3N2, the influenza A, you should probably be using the high dose vaccine. Next slide, and yeah, maybe the next slide after that too. Okay, so here's some good advice from some smart people. One from the World Health Organization: the most effective way to prevent influenza and or severe outcomes from influenza is vaccination. And then from our Public Health Agency of Canada, vaccination is the most effective way to prevent influenza and its complications. And so I'll leave it at that. So thanks for having me. And sorry I had to be a little bit agile and bounce around that presentation, but I thought it was best to just get done before the end of the hour.
Thank you so much for that really informative presentation. That was great. It's really eye-opening to understand how flu really impacts those with chronic disease, especially since we have such high rates of chronic disease for older adults especially. Okay, let me see. I did see one Q&A from Pam. If you have an anaphylactic reaction to the H1N1 vaccine with several issues afterwards, including in bed for 6 weeks afterwards, is it advised to receive the flu and the COVID vaccine this year?
Just the question: an anaphylactic reaction to something that's in the vaccine?
Anaphylaxis to H1N1. I could take it if you want.
Yeah, sure.
So the answer for COVID vaccine is very straightforward. There are no shared components in the COVID vaccine with any other vaccine. So absolutely can safely receive COVID vaccine. We watch people in the clinic for 15 minutes afterwards, just in case of a rare event, allergic event. So we usually watch people who have had a reaction to another vaccine for an extra 15 minutes just to be on the safe side, but definitely safe to get the COVID vaccine. And absolutely would be recommended to get an influenza vaccine as well. We would just want to check the components of the H1N1 vaccine against the vaccines we're using. We have several choices, as we've shown you. So the pharmacist or whoever's giving the vaccine would just cross-check to make sure there's no shared components and give one that doesn't have any common things, since we won't know exactly what caused the allergic reaction. Sorry, Dion, I've answered that question about 7,000 times in the last couple of months, so I figured I'd jump in.
It's okay. No, thank you very much.
And I just had one other question that someone asked for clarification. Similar to COVID, if you get vaccinated with the flu, are you protecting others with chronic disease?
Yes, because you're preventing transmission, or you're certainly preventing as much transmission as the vaccine will allow you to. I mean, you can still transmit a little bit, but from 100% down to 10%, less than 10%. So yeah, I mean, you vaccinate really because you want to protect yourself, but you vaccinate because you want to stop transmitting to people that might be vulnerable. Again, as for Dr. McNeil's points, you vaccinate because you want to prevent people from getting to the hospital and overwhelming our healthcare system, which is grossly overwhelmed right now. And of course, you vaccinate because it really does help us in regard to our healthcare costs in general and our economy in general.
And then I have 2 other questions if we have time. Is the pneumonia vaccine important in addition to COVID-19 and the influenza vaccine?
Dr. McNeil?
I could take that one too. Yeah, so pneumonia vaccine is also very important for older adults or adults of any age really with underlying health problems, because those folks are all at increased risk of pneumococcal disease, or the bacteria that vaccine is preventing against. So absolutely, we still see those illnesses despite what's going on with COVID, and protecting yourself against pneumonia and the diseases one of the bacteria that cause pneumonia is really important. So get your pneumovax. You can also get that at the same time as your COVID vaccine. If you're now going, oh wow, I guess I better go get this done, you can do them all at the same time if you like.
And then I have one more. I went to a pharmacy and got my flu shot. Now I think I should have gotten the shot for the high dose shot. What can I do?
Well, it's not recommended that and it's not in the Canadian label for high dose, that you should get a high dose vaccine after you've got another flu vaccine. So next year is your time.
Amazing. Well, I think that is the end of our questions. Thank you so much for sharing your wealth of knowledge with us today. It was incredibly informative to understand all of the underlying issues around influenza and the importance of the influenza vaccine that maybe many people don't even think about or are aware of. So thank you for taking the time of your day to share with us. And thank you for our attendees for joining us today. This was so great. We had some great questions and it was great conversations, and we will be able to review our webinar on our Facebook page and our website shortly. So thank you everyone so much today for joining us.
Thanks everyone. Have a great day.
Thanks.
Good day.
Bye.
Bye.
Bye.